Imagine an adolescent male who suddenly begins sleeping up to 18 hours a day. When forced awake, he is profoundly lethargic, his cognition is severely slowed, and he exhibits complete apathy toward his surroundings. If a clinician examines this patient during this acute phase, the snapshot points toward a few obvious conclusions. Based on a single consultation, the presentation closely mimics atypical depression, idiopathic hypersomnia, or narcolepsy. To accurately identify Klein-Levin syndrome, practitioners must look past the immediate symptoms of the acute attack and examine the patient's presentation across a longitudinal timeline. This graph highlights the structural difference between chronic and episodic conditions. On the left, chronic hypersomnolence presents as a continuous, elevated baseline of excessive sleep. On the right, episodic hypersomnolence shows a completely normal baseline, violently interrupted by massive, multi-week vertical spikes of extreme sleep. Look at the flat spaces between these sudden attacks. In Klein-Levin syndrome, patients return to an uncompromised neurocognitive state between episodes, functioning normally. Applying a chronic diagnostic framework to these transient symptoms results in a systemic mismatch. When clinicians treat the acute episode as a permanent state, patients are often prescribed daily psychiatric or stimulant regimens for a condition that will spontaneously resolve in days, leaving the true underlying cycle unaddressed. The clinical reality of Klein-Levin syndrome extends beyond prolonged sleep. It is a multi-system failure that disrupts sleep, appetite, and behavioral regulation through a single localized dysfunction. This 3D model of the human brain highlights the hypothalamus. Current research points to transient dysfunction in this specific region as the primary driver of the disorder. The hypothalamus regulates several key autonomous functions. First, it controls our sleep drive. During a KLS episode, this pathway dysregulates, pushing patients to sleep 15 to 20 hours a day. They become incredibly difficult to awaken and show deep confusion when roused. Second, the hypothalamus manages appetite regulation. When an episode strikes, this pathway also misfires, resulting in hyperphagia, compulsive, excessive eating that occurs exclusively during the attack. Finally, the region influences behavioral inhibition. Impairment here triggers intense cognitive and behavioral shifts. Patients display severe apathy, social withdrawal, and in some cases, distinct hypersexuality. The simultaneous failure of sleep, appetite, and behavioral control points to a highly specific mechanism. Researchers suspect a localized neurotransmitter imbalance, or possibly an inflammatory or autoimmune trigger directly affecting the hypothalamus. Tracing these seemingly disparate behavioral symptoms back to a single neural network provides crucial clarity. It allows clinicians to distinguish a physiological neurological disorder from a primary psychiatric illness. The onset of Klein-Levin syndrome follows a distinct demographic pattern. It overwhelmingly begins during adolescence, and it strikes males significantly more often than females. These episodes rarely occur in a vacuum. They are frequently precipitated by an external trigger, often a viral infection, but sometimes acute stress, alcohol use, or severe sleep deprivation. This timeline charts a typical patient's disease course. Following the initial trigger, such as a viral illness, the patient plunges into a continuous symptomatic episode. Zooming in on this symptomatic block, the scale reveals that a single KLS episode persists relentlessly for days or even weeks at a time. When we zoom out to view multiple episodes across several years, the most critical diagnostic feature emerges. In the spaces between these attacks, the patient's baseline returns completely to normal. There are zero residual cognitive or behavioral deficits. This absolute normalization of neurocognitive function between attacks is the definitive clinical signature of Klein-Levin syndrome. Medicine has not yet identified a definitive biomarker or blood test for KLS. A confirmed diagnosis relies entirely on systematic clinical evaluation and rigorous exclusionary logic. Polysomnography, or sleep study data, offers specific evidentiary weight. During an episode, results show a massive increase in total sleep time, but the underlying sleep architecture remains unremarkable. Between episodes, the data is even clearer. Polysomnography reveals completely normal sleep architecture, perfectly matching the patient's normal behavioral baseline. This comparative matrix maps KLS against similar conditions, starting with narcolepsy, to build our differential diagnosis. Unlike narcolepsy, which presents with persistent abnormal REM sleep architecture and daily sleep attacks, KLS maintains completely normal sleep study findings and a normal baseline between distinct episodes. Evaluating idiopathic hypersomnia and major depression against this matrix isolates KLS entirely. Across all 4 conditions, Klein-Levin syndrome stands alone because its behavioral profile is purely episodic, whereas the others present with chronic, continuous symptoms. Diagnosing KLS requires tracking the patient over time and systematically excluding these chronic disorders. No single positive test result can confirm it. Because the exact pathophysiology remains elusive, there is currently no cure for KLS. Clinical management is strictly supportive. During an active episode, the primary medical objective is keeping the patient safe. Caregivers must closely monitor the patient's nutrition, maintain hydration, and ensure physical safety while they remain severely impaired. Pharmacological interventions offer limited help. Stimulants and mood stabilizers are sometimes prescribed to reduce excessive sleepiness, but their results are highly variable and generally unreliable. This 10-year timeline illustrates the long-term prognosis. Klein-Levin syndrome is ultimately a self-limiting condition. The episodic spikes gradually decrease in severity and frequency. The disease course typically spans 8 to 12 years. Episodes progressively fade out until they cease entirely, leaving a permanent normal baseline. Klein-Levin syndrome demonstrates the profound, localized connections between sleep regulation, behavioral control, and the maintenance of human consciousness. By recognizing the episodic nature of the disorder, clinicians can stop prescribing futile chronic treatments. Instead, they can provide patients and their families with the precise prognostic reassurance required to navigate a decade-long ordeal.